I'm Dr. Alana Yurkowitz, and this is Hard Medicine. Cancer is complex. As an oncologist and primary care doctor, every day I see the full spectrum of it. I see patients cured 20 years ago now living their lives with few scars. I see people navigating the long, medically messy aftermath of treatment. And I see those with metastatic disease losing function, independence, or life. My guest today, Dr. Azra Raza, has made her life's work one deceptively simple idea. Stop chasing the last cancer cell. Chase the first. This is a brilliant framing I'm in agreement with, and one I think only someone routinely seeing patients, not siloed in the laboratory, can arrive at. Azra is not just a practicing oncologist. She's also a cancer widow. We have both seen the chaotic, unpredictable devastation cancer can wreak on the human body when it breaks free. You'll hear in this conversation we don't agree on everything. Something I say is that it's a yes and, not an either or. I believe prevention also includes systems reform and practices like identifying high-risk patients and getting them the screening, surgeries, and medications known to reduce risk. It includes epidemiologic research on why cancers are rising in young adults now compared to generations prior. It includes both the biologic reality and the systems people move through. My perspective on this is informed by the preventive oncology clinic I created and run at Stanford. But where we are in full agreement is the emphasis on chasing cure above prevention, and how this is a limited and sometimes even futile approach. The best cancer care doesn't necessarily mean cure. It means reducing suffering from cancer. And there is so much we can do to get there. I firmly believe with a shift in thinking, many lives can be saved and suffering alleviated before it begins. Since the time of Hippocrates, medicine has recognized a core principle. Prevention is preferable to cure. But it doesn't always happen in practice. Why is detecting cancer early still a second-class idea to prolonging remission? Why does the bulk of research funding go toward late-stage disease? What needs to be done scientifically and practically to change this? This is a conversation about cancer that is both critical and very optimistic. Dr. Azra Raza, welcome to Hard Medicine.
Thank you, Ilana.
So, we're both non-traditional oncologists. We've taken care of many patients with every kind of cancer at every stage and witnessed the suffering so often left in cancer's wake. Oncologists typically focus on treatment. I started and run a cancer survivorship and prevention clinic at Stanford, and in 2019, you published The First Cell about your focus on prevention and early detection. How did you get there?
Let me say what a pleasure it is to be in conversation with you because our thinking about a lot of these issues is very well aligned. And so I think we can have a discussion where there are areas we'll disagree, but areas a lot more in common with each other. I began to think about early detection actually when I first came to America and with the whole idea of curing cancer, not prolonging life for patients with cancer, but actually finding a cure for the disease. And I started studying and treating acute myeloid leukemia patients. But very quickly, it became apparent to me that in my lifetime, this disease is so deadly, it can't be cured. And so I asked myself, what's the only good news we can give a cancer patient? It is that, hey, we found it early, we can cure you. In other words, finding a disease, cancer, early is good. Well, how do you define early? How early should it be? And how should I find acute myeloid leukemia early? Because by the time patients present with any clinical symptom, there are billions of cells all over the body circulating in their blood that are cancerous. So that's when I decided in 1984 that in fact, the only way to find this cancer early is to find individuals who are at risk of getting this cancer. And those are patients with pre-leukemia who just have dropped their blood counts, and a third of them will develop acute myeloid leukemia. And so I turned my attention to pre-leukemia MDS patients and following them throughout their course until they either died of their disease, MDS, or developed acute leukemia and died. That was one important decision about studying cancer early and trying to prevent and intercept before it became a deadly cancer. And the second important decision I made at that time was that if I'm going to cure cancer, I should have human tissue to study. And I started banking samples of blood, serum, plasma, marrow, biopsy, saliva, everything I could get hold of. And today I have the largest tissue repository of 65,000 samples longitudinally obtained on my patients as they go from MDS towards dying of MDS or developing leukemia. And this is now an invaluable repository of human tissue because we have the perspective of time going back. Some survived 10 years, some died within 6 months. We can find differences. But to come back to your question, I had been right from the get go after arriving in America and starting serious research within a few years, turned my attention to early detection. And how early should it be? As early as before cancer makes its appearance, starting to study patients with high risk. And then something horrible happened at a personal level to me. I had been an oncologist for 20 years already, seeing patients, treating leukemia, Ilana. And then suddenly, my own husband, who was the head of the cancer center, Harvey Preisler at Rush University in Chicago, was diagnosed with his second cancer. The first cancer was a solid tumor when he was 36. He survived that. At 57, he develops lymphoma, leukemia that ends up killing him. So when Harvey was diagnosed, it was like the ground split beneath me. I didn't realize how painful a disease it is, despite being a doctor and oncologist for 20 years, until I shared a bed with a cancer patient. Here was the man who had devoted his life to cure cancer since he's 15, and yet he found himself on the receiving end of the very disease he had battled so valiantly. And I wasn't just his oncologist, but also his wife and the mother of our 4-year-old daughter. So every decision became both clinical and existential. Every treatment was a test of hope. Every moment got threaded with the unbearable knowledge of what was slipping away. And those 5 years were such a brutal apprenticeship in the limits of our science, at the depth of our humanity. Harvey died in my arms, under hospice care, after enduring what I can only call a torment. And that grief reshaped everything and gave me the moral courage to stand up and start speaking about it as well.
Well, thank you for sharing that. Thank you for sharing Harvey's story in the book and Harvey's story right now. And I'm so sorry you went through that. Your daughter is now grown. She's in her 20s, I believe, and thriving. That was actually a line that I underlined in your book. Cancer is what I've been treating for 2 decades, but until I shared a bed with a cancer patient, I had no idea how unbearably painful a disease it could be. That leads me to the paradigm shift that you have been arguing for a long time now, for decades, but I think really came to public attention when your book came out in 2019. You tell in the book stories of patients that you've cared for, in addition to Harvey, I would say in some excruciating detail of the suffering that they endured once, I would say, the horse was out of the barn. Once cancer had escaped its initial location and metastasized, all the complications, all the downstream complications that just wreak havoc on the human body. And I will say, I've seen and taken care of patients with that fair share of extraordinary suffering. There are many cases that stay with me, but one I'll share is there was a patient I was caring for in residency who was 2,000 miles away from his family, where a tumor in the spinal cord led to paralysis from the neck down suddenly and irreversibly. And he begged me to give him a medication just to end his life. Wasn't even thinking about treatment. And so that led to your paradigm shift, which is essentially, again, once the cancer cells are spread, they're too complex to cure because the human body is complex. If advanced cancer is so biologically entrenched by the time we find it, why has so much of cancer research focused on extending treatment by weeks to months when the horse is already out of the barn?
So true. I was just in conversation with Siddharth Mukherjee at a local club here last week, and I was asking him questions, letting him answer the question, and then I answered the same question myself. And one of them was, what is the most basic fundamental mistake or misunderstanding we have had about cancer that has led to so many incorrect decisions? And Sid's answer was that it's completely ignoring the soil and only going after the seed. And then he built on that. But Ilana, my answer was more general in the sense that I feel that the fundamental mistake and assumption we make about cancer incorrectly and on which we base our treatment is that there is a linear causality. One thing happens, leads to the next, lead. No, cancer is forever from the first moment the first cell is born. And until the cancer becomes visible, either in clinical symptoms or on a scanning imaging device, it has gone innumerable number of evolutionary steps, depending on its microenvironment, on 1,000 things that are related to just the host's body and responsiveness to the increasing clone size. And so you cannot predict anything, even in the same individual. If the same cancer lands in another site, you can't predict it. So basically, late stage intervention reveals to me an epistemological failure, one rooted in how we know what we choose to measure and what we value in the architecture of modern medicine. I've come to the conclusion that we are brilliant at cataloging the molecular wreckage of advanced cancers, but we are strangely blind to the early subtle shifts that precedes this catastrophe. Our research priorities have long favored this dramatic over the preventive and the visible over the incipient. We go to med school because we want to treat disease. So, in this sense, our dependence on late stage intervention is not merely a clinical problem, it's a failure of imagination, a reluctance to ask difficult questions, different questions about the nature of disease and the timing of care. But as I was just telling you earlier, it's also the failure is not just epistemological, it's a moral failure. Because by the time we intervene, patients are often exhausted, vulnerable. They're cornered by a system that makes mistaken interventions. We treat the end game with the full force of technology while ignoring the quieter signs of prediction, prevention, dignity. A true wise system, in my opinion, would invest its greatest intelligence in forestalling that moment when such intervention becomes necessary at all. And the fact that we don't do that, to me, suggests a deeper confusion about what constitutes success, not just in science, but in the stories we tell ourselves about life, about control, about cure, about dignity.
Yeah, I completely agree with that. I'm of the opinion in medicine that prevention just never gets the same fanfare that rescue does. And so getting into a research shift requires just a fundamental change in thinking and celebrating prevention as the extraordinary success that it is, and not seeing rescue only as that extraordinary success. From my perspective, I take care of hundreds, more than hundreds of cancer survivors who didn't die of their disease, thank goodness, but treating the last cell and treating the disease once it was already advanced led to all of these long-term complications that they're living with. Things like premature menopause, infertility, osteoporosis, cognitive changes, fatigue that they are dealing with for years and sometimes decades after the fact.
Yeah.
I cited some numbers in your book about the research landscape. I would love if you could tell me if this is still the case, because these were really extraordinary. The failure rate for drugs brought into clinical trials with preclinical drug testing platforms was 95%. And then this is a direct quote from you, which I also underlined. The 5% of drugs that reach approval might as well have failed since they prolong survival by no more than a few months at best. Is that still the case?
In fact, I updated all this because of the latest statistics released in 2023. And I had one of my students at Columbia make the slides for me to show at Grand Rounds. And the slide says 87.7% of phase one clinical trials fail in cancer. And in fact, by if you include stage two and three, then it's 95% still. And do you know how much money we throw away on this? Between 50 and 60 billion dollars. I come from a country, third world country originally, Pakistan. They are a country of 255 million people. And do you know what is the country's budget? $34 billion. Here we are throwing away 50 to 60 billion dollars in phase one failed trials only for cancer.
People probably have pushed back on you. We've talked about this before. I would say there's a few areas that I was curious to hear your opinions on. One is immunotherapy, as well as cellular therapies. I've had patients with AML, your disease of specialty, that have been cured by bone marrow transplants. You're still treating the lost cell, but they are cured by some of these technologies.
I mean, I have a very straightforward answer to this question. First of all, I take my cue about prevention and early detection, a lot of it from cardiac surgeons. You know why? Because they realize that, in fact, the most powerful interventions are not heroic like heart transplants, they are preventative. They shifted their focus from heart transplants to stents and statins 30 years ago. In oncology, we are still at the heart transplant stage. We are still doing bone marrow transplants and slash poison burn. You're talking about immune therapies. Well, what I'm going to say to you is that, of course, immune therapies and all the treatments that have prolonged people's life, there's no denying that these treatments that were unimaginable a generation ago are extending lives of patients in very real ways. I mean, look at lung cancer. Stage four patients are living longer, but all of that is a minority. Immune therapy, targeted therapies, even the precision with which we can match a drug to a mutation, these are genuine triumphs. But there's a tension here, Ilana, that much of what we call success in cancer treatment is still measured in increments. Months added, progression delayed, curves modestly shifted. And at what cost? There's a lot of side effects that come with it. So, my question is not whether treatment is advancing, because it clearly is. The question is how to shift the current outcome from incremental for a minority to a radically improved one for the majority. This has been my whole life's quest.
I think we can recognize some of the genuine triumphs while also recognizing what a slim proportion of patients they end up serving. I wanted to read another quote from your book that I will say this is a very serious book, and this quote made me laugh out loud. It was about mouse models, and then I'd love to for you to expound on your thoughts on mouse models. Okay, so I'm going to read this passage. I met a young male researcher recently whose ego was so dense, light would bend around him. He presented a seminar at Columbia where he described mouse models carrying a mutated gene associated with myelodysplastic syndrome, or MDS, which is the precursor to leukemia. That's me ad-libbing. He also presented data that administering a drug that inhibited activity of the protein, not the mutated protein, was curing whatever disease he had inflicted upon the mice. When I asked him what gave him any confidence that the results of the drug therapy he showed in mice would have value for humans, he scoffed, "Sorry, Azra, mouse models are not going away." And you wrote, "That was already 2 years ago. I am sure he has cured a lot more mice since then." And so there are two parts that made me laugh. The ending also made me laugh as I picture this researcher saving the lives of millions of mice. So Fundamentally, what is wrong with mouse models?
Well, one thing wrong is that too many mice are running around the New York subway cured of leukemia. But
Those mice are doing great. Lucky them.
yes, they're pretty fattened up. They look like rats now.
I
But
haven't been to New York in a while. I haven't had the pleasure.
oh no, any New Yorker will empathize immediately. But listen, Ilana, I'm scared of you because you've really read the book very carefully. I can see and mark passages that make sense to you, and I'm very grateful for it because, in general, all my colleagues have treated me like I've written the satanic verses. Can you imagine that no oncology society has ever invited me to speak or present my work or allowed me or accepted even my abstract in the last 25 years? 25 years they have been ignoring me completely because they refuse to acknowledge this message from me. And this is my message that becomes very painful to everybody is about mice. Why is that the problem? Because 90% of research being done is on models, like animal models. And I say that no mouse can ever truthfully represent a human. And I'll give you just a couple of reasons why I say that. When I came to this country, it was January of 1977. My residency wasn't going to start till July. So I had 6 months. And I was convinced, Ilana, that somebody is going to cure cancer in 6 months and I will be left behind. So I showed up at the local, in town, there was this great institution, Roswell Park Cancer Institute in Buffalo, New York. I showed up there and they gave me a fellowship in pediatric oncology for those 6 months. But within 2 months, they wanted to kick me out, not because I was stupid or anything, but because I was crying the whole time. I just couldn't sit on 2-year-olds' backs and push bone marrow needles or lumbar puncture needles into them. It was too painful. So they pushed me into the adult service and said, go and work there. You can't survive in pediatrics. And the first thing I realized when I started working in adult service was that the same combination of drugs that are curing childhood acute lymphoblastic leukemia had no effect on adults. And the same disease looks exactly the same under the microscope, but the bodies are totally different. A 70-year-old body, every cell has seen 1,000 cuts in it, whereas a 2-year-old's body is nascent and all the cells are virgin cells. They are hard to kill. They digest and metabolize things differently than a 70-year-old. In other words, the same drugs are not working at one stage and are working beautifully at another says that even a littler version of ourselves cannot serve as a model. So, how are we depending on mice? Norbert Wiener said in 1940 that the best model for a cat is another cat, preferably the same one. In other words, you have to individualize treatment for every person simply because the host responses and its interaction with the cancer are going to differ from patient to patient. And by the way, in 2014, my friend John Brockman, very well known book agent in New York, he was the agent for Andy Warhol also, and a wonderful intellect. He invites about 100 intellectuals a year to answer one question he gives. And in 2014 or 2015, the question was, what scientific idea is ready for retirement? And my answer was, the mouse is the elephant in the room. And I gave my whole reasons for why mouse models cannot replicate what is happening in the human body. And that got me, number one, my answer was picked up as headlined in The Guardian in England and beating out Richard Dawkins, Steven Pinker, Alan Alda, Daniel Dennett, all kinds of luminaries who are my heroes too, by the way. But because this was such a novel idea to people that mouse models shouldn't be used for cancer research, not I'm not talking about trying to find signaling pathways and all. All I'm saying is mouse models are not faithfully representative when it comes to drug development. But then John Brockman again came to my rescue in 2018 and said, Azra, that answer you gave, plus you're always, he's a good friend also. So he goes, like, you're always going on and on about all that is wrong in oncology research. Why don't you write a book? And I said, because I'm not a writer. I'm here to study and treat cancer and cure cancer. I'm not going to write a book. For 2 years, he went on at me till he forced me to do the first cell, because no mouse can have night sweats that can be catalogued. But humans, like my own husband Harvey, when he had cancer, the opening 2 pages of the book describe the deluge of sweat that would pour out of his body 2, 3 times a night and 2, 3 times during the day, requiring clothing changes, bed sheet changes. And you can't do all of that in mice.
I want to get into your tissue banking that you've been doing for a few decades, but just right before I do that, I have to ask, you've gotten so much resistance for these ideas, and I understand that it challenges people's pre-existing mental models of how research should be done. But if they see the failure rates of mouse models once they're extended into humans and how these drugs essentially don't work, how has the scientific community not shifted in their thinking yet?
Because if your paycheck depends upon sticking to the old model, you can't afford to shift, Ilana. That's it. It's the financial incentive.
Yeah.
So, in my opinion, it's not just the researchers, it's our institutions that have failed completely, because they are also populated. Institutions are populated by individuals who are all deciding this same kind of circular logic. I'm telling you that we shift the focus from the last cell to the first cell and financially incentivize a revolutionary early detection of cancer, not stage one, but first cell stage, inception of cancer. The whole field will shift with that financial incentive.
And no young researchers can pursue this if there's no funding to support it. So,
Or they can't afford to take risks because
yeah,
they still have to publish a paper in Nature. They still have to get that tenure.
right.
So
Career
they're not going
risks.
to take any risk.
It's a broader statement about how science research is funded, and it's very hard to take big risks because grants just tend to fund a little incremental change in whatever the pre-existing thinking of the community is. So doing something radical like what you've been arguing for, this does lead into, I want to ask you about your tissue bank because you just started doing this on your own, is my understanding, right? Like it's not like you had a grant to save your patients with myelodysplastic syndrome, their blood, their marrow, their saliva. And for decades now, you have kept this biobank of human tissues. What have you learned from that over the decades, and what are you working on now?
That's an incredibly important and interesting question. Yes, the biobank is completely funded by me and me alone. No grants, no support from the university or any institution ever. The most important people who support my grant are my own patients who want to give me money. I never accept personal money. I go like give it to my research and that supports, but it costs $1.4 million a year just to keep the tissues I have collected. And how do I raise the money? Through fundraisers, through benefits, through philanthropy, through patients, through doing some research on those samples and getting sponsored research agreements that actually also yield important things. But you asked me about what I'm doing now and what have I learned from the tissue repository. My answer is that at the moment, Ilana, you and I are a witness to a transitional moment in the history of medicine. And basically, there are three profound shifts that are going to happen now and are in the process of happening. Number one, the recognition that cancer begins far earlier than medicine is willing to admit. We only admit it when we see it actually through a biopsy or through an imaging or scanning device or through clinical symptoms. But in fact, it started way before. And number two, the profound shift is that we will abandon models and learn directly from human tissue. And three is that all of healthcare, not just oncology, has to shift from reactive to interceptive oncology, interceptive healthcare. I learned my lesson from Thomas Kuhn. In 1963, he published his book, The Structure of Scientific Revolution. Basically, the point that I love in that book is that, so you don't like the current paradigm. You want the paradigm to change. Well, show the success of the new one. So here is what I'm to show you, the success of the new paradigm. And I'm holding this up for you. I know that this is not a video recording. So for the audience, what I'm holding up for Ilana is a syringe with a needle. The syringe is empty. I'm saying to Ilana that this contains the cure for cancer. So what is this cure for cancer? It's not in the syringe, it's a needle. What is in the needle? 10 years ago, I started working with our biomedical and bioelectronics engineers at Columbia University. In fact, in the book, I have written about Samuel Sia. Professor Sia is the head of biomedical engineering here, brilliant scientist, and Dr. Ken Shepard, who I started working with later than that. But basically, I realized, Ilana, that I'm trying to find the first leukemia cell in my pre-leukemia patients. Well, a leukemia cell is larger than the largest white blood cell in the blood. So my idea was that I should be able to filter the blood of pre-leukemia patients and see if I can trap the first leukemia cells from the blood. Use blood as a window into disease. Don't wait for the bone marrow to become replaced by leukemia cells when it becomes an end stage monstrosity that cannot be treated. So in 2015, I fitted my lab with these technology provided by Rare Cells, a brilliant company in France. And this is a filtration device through which we can pass 10 cc's of blood and it will catch cells larger than the white cells. And we started to find not just leukemia cells, but these giant polyploid cancer cells. And it turns out that this polyploid giant cancer cell, which is known by many names, is cancer agnostic. It's present in every cancer, in fact, and is associated with genesis, metastasis, and recurrence of cancer. There's a whole literature on it, which since 1911, this cell has been described. And every decade, investigators have found and substantiated the presence of this cell as one of the first culprits that causes recurrence. So I wanted to find this cell in cancer survivors. For example, let's say I have lung cancer and I'm given surgery, chemo, radiation, immune therapies, everything, and then I'm declared cancer free. But my chance of recurrence is high because it was stage 3B cancer. Now, how do I catch that first cell of recurrence? That was the problem for the biomedical bioelectronics engineers. And what they did is so dramatic. They took the coronary stent. So, as I told you earlier, we learned from our cardiovascular folks. They took the coronary stent, Ilana, and they fabricated electronics onto the device, onto the stent. And it is their genius of miniaturizing these electronics. And then instead of putting it in the coronaries, you place it in the cephalic vein in the arm. Why here? Because it's superficial and a little device, a patch device can sit on the skin outside and power it continuously through ultrasound. And as a result, within the stent that is now inside the vein, an electrical field is created. So any cell that passes through that field can actually will cause impedance of the electric current, which will be picked up and recorded on that stent immediately. So if the cell is small, the signal picked up is small. If the cell is large, the signal is suddenly large. Not only will it detect that large cell, it can electrocute it on the spot. So here is a stent that biomedical engineers, after $100 million in grant research, have brought it to a point where it is ready for being tested. So by training AI machine learning platforms with billions and billions of normal versus cancer cells, So basically, the technology, the technologic revolution is right upon us now. I'm holding it up for you. I'm telling you that the miniaturized, automated, implantable devices that are capable of detecting the earliest changes that transition us from illness, wellness towards illness, backed by the power of AI technology, is here to shift the whole healthcare paradigm. But these paradigms don't shift just from technology, they need a moral courage behind it. And where is our imagination? Where is our moral courage? It's completely missing. And I have refused to accept that, and I'll continue to refuse to accept it.
Are there any other cells that are giant cells that it could electrocute by mistake, that it thinks it's a cancer cell, but are there other cells in the body where this is
So
prone to
what?
errors?
Well, why would they be circulating in the blood? Macrophages don't belong in the blood. Monocytes can. Macrophages don't. These are cells that are the size 100 to 300 microns. You can't mistake them for a 15 or 30 micron cell. Even if it kills a megakaryocyte or a macrophage that happened to come in, so what? In 1911, Otto Eichel, this German physician and researcher, said that in fact cancer metastasizes because a tissue cell fuses with a blood cell. And this is how it can get out of its organ of origin also, because it hitches a ride on a blood cell and now can go and land in other organs. This cancer hybrid cell, which is a combination of a tissue cell and a blood cell, that ends up creating the giant cell, which is the cell of recurrence. And if we can take it out, we can prevent recurrence. I'm quite confident about that. I would like my first subjects to be cancer survivors. And then once we show that we detected the recurrent cell and we were able to take it out and prolong or delay recurrence even, that will be a huge deal, Ilana.
I would love to have you back on in a year and hear about the progress of is it Stentinel? Did I say that correct? Okay. Very exciting stuff. I did want to switch gears a little bit and talk about screening, but I think cancer survivors are the perfect segue to do that. As you know, there are certain subsets of the population that are just at higher risk for cancer than other subsets of the population. And the way we approach cancer now from a screening perspective is kind of this one size fits all approach. So, the USPSTF, which gives recommendations to primary care physicians on how to screen patients for cancer, only has validated recommended screening for really four different types of cancer. You do pap smears when you turn 21, you do mammograms when a woman turns 40, you do colonoscopies or stool tests for colon cancer screening now the age is 45, and you can do low dose chest CTs, but only for lung cancer screening for patients with a history of smoking and a pretty significant history of smoking.
And
There's
PSA,
there's
don't forget.
also, yep, and then PSA is per shared decision making. So it's one of those that's not strongly recommended by the USPSTF, but it tells physicians have the conversation with your patient and make a decision together because they're not perfect screening tests. So if you look at the success rate of screening for the general population, it's only about 14% of cancers that are caught by this general screening. It goes up to 25% when you include PSA, so I'm glad you brought that up. But as you know, we don't have good screening for the general population currently for ovarian cancer, for pancreatic cancer, for liver cancer, for many other types of cancers. And we know factors that increase somebody's risk. Cancer survivors are a great example of that. It's actually 20% of tumors are second tumors among survivors who have already had cancer, and that can be from many different reasons, including the toxicity from the treatment they've received. We also know that 5 to 10% of cancers are due to genetic inherited mutations. So these are called hereditary cancer syndromes. People listening might have heard of things like BRCA, BRCA mutation, or Lynch syndrome. And again, that contributes to 5 to 10% of all cancers. And then in practice, the vast majority of those people do not know their genetic status. until they've already been diagnosed with cancer. And so I will share my bias. This is part of the clinic that I've opened is the Cancer Prevention Clinic for high-risk patients, which is identifying this subset of the population that is at elevated risk and then systematically getting them into clinic, doing a comprehensive risk assessment and risk reduction, which includes more advanced screening. From your perspective, this is more of a systems question, not so much a science question. Why have we been so poor at doing risk stratification, at not treating people like one size fits all, but figuring out who's at high risk for cancer and getting them the testing and the preventive treatment that they need?
Well, I think I would be basically redundant if I keep repeating myself because people just don't care about early detection. I'm sorry to say. They keep writing about how terrible these tests are and how population studies have failed, etc., etc. But because tests are bad doesn't mean the idea of early detection is bad, for God's sake. You need to develop better tests. So where's the support for that? Nowhere. I'm telling you that we are literally the last generation that is going to be doing things in this pathetic caveman like way, building everything around visible disease. What we need to do is not to watch out for cancer to announce itself in someone with Lynch syndrome or someone with BRCA positivity. Look at the I would say, draconian measures that we offer to people who are BRCA positive is eviscerate them basically. Take out their ovaries, their uterus, their breasts, everything as,
Fallopian tubes.
yeah,
Mhm.
so mutilating, so horrifying. Why are we doing all of that? Imagine somebody having a stentinel. If they're BRCA positive, all the worries go out of their head because as the first cell comes, you keep zapping it out and then go to the organ where it was being produced and say this cell is coming from the pancreas, this cell is coming from the ovaries, and then you can go ahead and do limited treatment even now. But there has been no resources that have been invested in that area simply because 95% of resources are being used up. People attack me by saying, oh, you're ignoring all the patients we have now. I'm not ignoring all the patients. Of course, we have to do to everything to treat them. I am saying at the same time, more attention should be paid to finding this disease and developing this early. Why have we not done it for people who are at such obvious high risks? Why haven't we done anything why are we waiting for them to declare themselves on a mammogram? Or on a liver scan. I mean, I think it's completely criminal not to have been doing this. If I have one message to give to the future generation of scientists, it's like, look, we have spent a century in chasing the last cell. We have to stop that, turn our attention to finding the first. Second, human tissue contains real truths that no model can ever reveal. You just study human tissue. Why aren't you? I don't understand it. And the future is not on treatment, it's on surveillance, on interception, not episodic rescue like we are doing with these draconian measures. And not just technology is needed, but as I keep saying, courage is needed, vision is needed. Stand up to all this and try to find a better solution.
I think one place where we definitely agree is that it's not so much an either or, but a yes and. And we can still focus on better systems with the technologies that we have in place for screening and risk reduction while shifting the scientific research community and funding towards finding the first cell. My epiphany about high risk patients and screening and the reason that I started this clinic was very simple, that it was just being left to primary care physicians. And I did a whole other episode of why primary care is just completely overworked and not able to do this comprehensive cancer risk assessment and risk reduction in addition to everything else that they are doing in a 15-minute visit for 2,500 other patients. And so it just has to be a separate medical specialty. Um, Before we get to the final question, I do want to just end, we can do almost like a rapid fire with three areas that have exploded in public attention since your book came out. These are questions I get asked about all the time and I discuss with my patients every day. So I will probably give my quick opinions too. So, one, thoughts on Grail testing. So, for our listeners, there are now these, they're called MCEDs or multi cancer early detection tests. The idea is that it's screening for a general population beyond what we've already discussed, things like mammograms or colonoscopies, where it's a simple blood test that looks for circulating tumor cells for screening for the general population. What are your thoughts on that?
I think it's a very good test if it's positive. But if it's negative, that doesn't give me any confidence that I don't have cancer. However, a positive test, we shouldn't ignore the importance of it. And I think Gallery tests should be FDA approved, despite the failed national NHS trial in the UK.
Okay, I think we generally agree. I think it's going to get FDA approved. My
Yeah,
opinion is that it needs to be risk stratified a bit more about who benefits from it, and it might be just a high-risk patients rather than everybody currently. What
yeah.
about your thoughts on full body MRIs? I'm sure you've had patients ask you about those.
Listen, I'm getting them myself because I think if you find something, it's great. But a negative one, once again, as I said, and this is the failure that episodic tests are inherently inaccurate. But it's the best we have, so I get them also.
And just quick follow-up to that, your thoughts on incidentalomas. So these are things that the full body
Yeah,
MRI is going to find. They're not going to turn pathologic or they're not going to threaten somebody's life, but it requires then a lot of follow-up.
not a lot, but some follow up, and I think that follow up could save millions of dollars in treatment if that we didn't have this. If we didn't find it. So absolutely, I think it's so overblown, this whole area of in whatever you call it, in, in what did you call it?
Incidentalomas.
Incidentalomas. These incidental findings, which are obviously unintended consequences of technology. But once you start following someone like me who's been getting annual things for a while, if something new appears, I'll be worried about it. I'll follow it. Yes.
Yeah. So again, I think for the most part we agree here. I
Yeah.
actually really don't like the argument that says that physicians are then obligated to follow up on everything that they find on something like this because we're not automatons, right? The whole point of medicine is that you do what's clinically recommended for a patient, and you might just say, this is not going to cause you any harm, and tell the patient that, and then you don't need to do any follow-up on certain things that are found. And I think people can handle that. That's my
Of
opinion.
course.
I do think this also needs to be risk stratified more for the general population. All right. The third thing, there's this trend that the American Cancer Society has reported extensively on of younger people getting cancer. So these are adults in their 40s, 30s, or even 20s. Colorectal cancer is the one that's gotten the most public attention, but there are over a dozen other cancers that are rising in young adults that we've classically associated with aging. Why?
I don't think we know how they happen in aging adults. So why would we know how they happen in younger people? I don't have an answer.
What about some exposure? The leading theory, we don't know what exposure it is or whether it's one or multiple exposures that now younger people are getting exposed to that older adults in previous generations weren't, whether it's sugar sweetened beverages, processed foods, we don't know.
But Ilana, this is all we've been saying for 50 years for cancers in general, haven't we?
Yes, but historically, aging, is the number one risk factor for cancer, and it has been a pretty dramatic shift if you look at population data.
Of
People
course,
in
it's a
the,
dramatic shift,
yeah.
and we have no idea, and I refuse to accept any of these things that you're suggesting. Even you can't believe any of them is actually the truth. You're just saying it's possible that it could be exposure at an early age, it could be this, it could be climate change, it could be the plastic in our bodies. I mean, we can go ahead and talk about this till we are blue in the face, but the basic answer is nobody knows. Nobody knows how cancer starts to begin with in any body, and nobody has any idea why it's increasing in younger people today. And if they say they do, they're living in a delusional world.
Yes, I agree with that. We don't know now. I really support research to get to the bottom of this because I think then there are actionable policy changes like what we did for tobacco, right? Where you can't smoke in public places. If you figure out, let's say I'm making this up, that it's sugar sweetened beverages in childhood that are leading to colorectal cancer in your 20s and 30s, preschools and daycares wouldn't be giving those out anymore.
I can see a young mother speaking. I like that.
That's another bias of mine. All
I
right.
know.
So, the last question, which is always tying it all together, given everything that we've talked about, is cancer preventable?
Absolutely. Not just preventable in the far future. I'm saying that the first 50 subjects will be walking around with the Stentinel in their arm by 2029.
All right, we have it on record, 2029. Can I get you back? Can I get you back in 3 years?
Of course, I say yes. And let me say one thing. Somebody interviewed me recently, and just for 1 minute, he said, three questions I'm going to shoot at you, and you have to answer 20 seconds. And the third question was very interesting. He said, what was that one piece of advice you were given as a young person that you dissed and said it's meaningless, but now you realize it's correct? And my answer was, money matters.
Yes,
So resources
indeed.
matter. I tell you, I came to America because this is the country that has the resources to support the research that I wanted to do. And number two, it is a country that recognizes merit. And it allowed me, an outsider, to come in and do all the things I had dreamed of doing and do them. And this is a country large enough where even if the establishment is against you, you as an individual can succeed because the country empowers you with the resources that are available elsewhere. So if the oncologists are not going to invite me or let me speak up in their meeting, the cardiovascular surgeons invited me. So there is enough place for everybody in this country, but resources are extremely important because science and technology is extremely important and it costs a lot of money. So I want everybody to hear that I'm a very practical person in this. I need to bring a solution rapidly to the bedside because I'm the one seeing 30 to 40 cancer patients a week and watching them die tormented deaths, and that should not continue. And this is my last message to all of you is those of you listening to this podcast, try to think of everything related to cancer with what are we doing to patients, not just current ones, what are we going to do to them in 5 years from now, in 10 years from now, and how can we do differently? And the best way is to find cancer before it finds us. And let's take it out and let's prevent it. And I think it's doable.
Dr. Azra Raza, thank you so much for joining me on Hard Medicine.
Thank you for having me. It's been an honor.
Thank you to founding member Matthew Beckman. If this conversation helped you see medicine differently, subscribe to Hard Medicine and share this episode with someone who should be part of the conversation.